In this video, we aim to describe techniques to manage an early pregnancy loss in the setting of a challenging dilation and curettage. Dilation and curettage, or a DNC, can be a straightforward procedure. However, the provider may experience difficulty in performing the procedure for various reasons. These include an extremely retroflexed or anteverted uterus position, adhesions or scar tissue at the external cervical os, a stenotic or tortuous cervix, or prior placement of a cervical or abdominal cerclage. This list is not exhaustive, and there are many other reasons a provider may experience difficulties in performing a DNC. If you know that your patient's anatomy will make it challenging to access the uterine cavity, you can start with medical or mechanical options. The medical option is misoprostol, also known as Cytotec, which can be administered orally, sublingually, or vaginally. Vaginal misoprostol may be more effective with fewer side effects compared to other options. Some studies have reported up to an 84% success rate of cervical dilation in management of first trimester miscarriage. If your patient prefers a non-pharmacologic option, you can consider placing a mechanical cervical dilator like laminaria or Dilapan. These dilators are placed through the external and internal cervical os and will expand as it absorbs water. Evidence has shown that placement of laminaria 8 to 12 hours prior to procedure demonstrated a 75 to 87% success rate, and it has also been proven to decrease the risk of cervical lacerations and uterine perforation. Prior to starting the DNC, many providers perform a bimanual exam to identify the size and position of the uterus. When ready to perform the DNC, operative preparation includes placing the speculum for proper visualization of the cervix. Then you will perform the paracervical block with vasopressin at the 4 and 8 o'clock positions of the cervico-vaginal junction. Vasopressin will help with managing bleeding. Prior to dilating the cervix, sounding the cavity can also provide insight into how difficult the dilation process will be. Additionally, it provides the surgeon the opportunity to gain a better understanding of the cavity and trajectory of the cervix prior to the placement of the dilators and curettes. Another way to sound the uterus is by using a transabdominal ultrasound. First, you will want to backfill the bladder with 200 to 300 milliliters of saline through the urethral catheter. Then, reattempt to sound the uterus under direct visualization. A study looking at ultrasound-guided uterine sounding for embryo transfer has been shown to be more accurate in identifying the length of the uterus in comparison to blind sounding. This trial can be applicable to preparation for a DNC, since the goal of sounding the uterus for both procedures is to identify uterine length. If you meet resistance while sounding the uterus, remove the sound and attempt to reposition the uterus using your tenaculum based on your bimanual exam. If you noted an extremely antiflexed uterus, you can place the tenaculum on the anterior lip of the cervix while applying gentle traction to make the uterus position more axial. Similarly, if you noted an extremely retroflexed uterus, you can place the tenaculum on the posterior lip of the cervix while applying gentle traction to reposition the uterus into a more axial plane. In some patients, scar tissue can be visualized at the external cervical os due to prior manipulation of the cervix after a loop electrosurgical excision procedure. If you identify scar tissue, you can attempt a stab incision to create an entry point at the external cervical os. Another anatomical variant you may encounter is a patient with a tortuous cervix. In this case, vaginoscopy could be an alternative method of accessing the uterine cavity. One study demonstrated shorter operation time, less pain, and 95% success rate with vaginoscopy compared to hysteroscopy. Though vaginoscopy is typically used as a diagnostic tool, it has the potential for application to DNCs. For example, if a patient has a tortuous cervix, under direct visualization of the vagina and cervical canal, you can use a 5mm scope to hydrodilate the endocervical canal and gain access to the uterine cavity. Once uterine access has been established, you can then proceed with the D&C. Using the os finder, make sure that the cervical os is in view. Take the smallest size Pratt dilator to dilate the cervical os. Sequentially increase the size of the Pratt dilator until optimal dilation is achieved. Then select the appropriate cannula based on the measured size of the pregnancy. As a general rule of thumb, the size of the cannula often corresponds to the patient's gestational age. After completing the number of passes required to evacuate uterine contents, select a sharp curette to perform a check curettage. Gently glide the sharp curette along the anterior, posterior, and lateral walls of the uterine cavity until a gritty texture is felt, with care to avoid perforation. This allows disruption of any adherent tissue and complete evacuation following one additional pass of the suction curette. Remove all tools from the uterine cavity and observe for appropriate hemostasis. If all attempts at accessing the uterine cavity through the cervix is unsuccessful, a possible option is laparoscopic entry. Although rare, there are some studies describing laparoscopic approaches to managing missed abortions at later gestational ages, or when a patient has failed in an attempt at a suction D&C in the presence of an abdominal cerclage. This technique enables the appropriate control of bleeding as well as controlled uterine entry with full visualization of the uterine cavity. Though needing to use a laparoscopic approach is not common, it is important for surgeons to be familiar with this technique in order to provide an alternative option when a D&C is not feasible. In this video, we laid out the various methods a surgeon can use to perform a challenging D&C. We discussed preoperative management with medical and mechanical cervical dilation. We also discussed using ultrasound to sound the uterus, using a tenaculum for repositioning the uterus, and performing a stab incision in the case of scar tissue at the external cervical os. Additionally, we discussed the benefits of vaginoscopy and, in rare cases, laparoscopy for uterine cavity access. The equipment used in this video is not the same as what would be used in the operating room in a sterile environment. However, it is meant to provide the surgeon with an evidence-based tool to better visualize the steps to navigate a challenging D&C.